It's not just gonna immediately be there.
So that means the complex cyst, it was more simple and then convert to
Possibly.
complex.
Possibly. Most of the time, I would say I would agree with that. We're good. Complex versus complicated, guys. Complicated. That's a Janae Echo song. I like that song. Okay. And this is an infected cyst right here, guys. You see the very, very thickened wall. Y'all see that right there? How thick that wall is? This posterior and anterior wall. Why can't I see this wall that well?
What?
Why can't I see these walls that well? I'm sure that it's just not thickened right there and right there. Why can't I see these walls well?
Artifact?
What kind of?
Steroids.
It's the artifact caused by this being a curved structure. Remember, same thing. That's why I want you always to line. Like for instance, you can't see the lateral walls of the aorta and transverse, right?
Mm-hmm.
You don't see them that well because they're a curved structure right there. So that doesn't mean that this wall is only thickened anterior and posterior. It's probably thickened on the lateral sides too. It's just because the structure is curved, meaning the beam is not hitting it perpendicularly, right? So it's going this wall is parallel to the beam, so you're not going to get those reflected sound signals the way you would get them on the anterior and posterior wall. Okay, but yeah, you can see on the infected cyst how thickened this wall is, thickened wall. And you can see the complex material within there. I'm sorry, the complicated materials within there. Okay. And of course, you guys have these same images in the book. They're better. These are the exact same images. I wanted to use those images out of the book. So, fibrocytic change treatment would be aspiration. If you can aspirate a cyst, sometimes, you know, it may be so thickened, or the fluid may be so thickened that you're not able to get anything from the aspiration. Everybody knows what a needle aspiration is, right? Okay, so you may not be able to get anything from it. Recurrent cysts may require excision. They have to be removed and may be diagnostic or therapeutic. Okay, large core vacuum assisted biopsy are going to be suspicious complex, cystic, and solid lesions. And this is just our little criteria again, guys. So simple cysts are going to be epithelial line fluid filled masses, 30 to 50 years old, are single or multiple. Signs and symptoms: asymptomatic, palpable, tender, oval, smooth, and freely movable. Okay. On mammography, they're going to be oval, smooth margins, higher density than the surroundings. Okay. Higher density than the surroundings. And sonography: oval, smooth, thin margin, absent internal echoes with posterior enhancement. Those are sonographic factors of a simple cyst. Fibrocytic change affects women 35 to 55 years old. Epithelial hyperplasia, adenosis, stromal fibrosis, and cyst formation. I may ask a question: which one of these is not considered fibrocystic change? You know, and I may have a couple of these with something else. Okay. That's going to be associated with tenderness, pain, fullness, nodularity, bilateral masses associated with Menzies and nipple discharge. Mammography is going to represent a bilateral rounded water density, masses, and benign scattered parenchymal calcifications. And multiple breast cysts, varying sizes bilaterally. That's how it's going to look sonographically. So, when it comes to the benign pathology, guys, this is how I kind of tried to break it down right here. So, we're going to talk about different types of cysts, including galactocele, milk cysts, and sebaceous cysts, the waxy substance. Okay? We're also going to talk about benign inflammatory conditions, such as an abscess and Mondor disease, and benign trauma-related masses, such as a hematoma, fat necrosis, and post-surgical scars. So this is the breakdown of the benign diseases we're going to talk about, okay? So I know it's a lot, but these are the...
What would I guess a lump look like? It would be a lump caused by like a hit, I guess.
That's gonna be like a trauma, like anything.
I guess. Can you see that or?
Yeah, on ultrasound. Definitely.
But
definitely.
could you tell that it was nothing? It's just
No, you can't. You can't. I can't say that it's nothing as a technologist, but us knowing all the factors that contributed to it, that's what's going to determine.
Yeah,
Oh,
those-
that's nothing versus something. Me knowing that, oh, just like for instance, the reason I say a car accident is because one of our students a few years ago, she got in a car accident leaving school, and she ended up having a huge contusion on her chest. And so we ended up looking at it and seeing that she had a hemorrhage on her chest. That's why I say because of trauma that you can develop hemorrhagic cyst. But yeah, it's a lot of factors that go into determining what this is and what we can rule out. Okay, so this is a breakdown of our benign masses right here, guys. Aside from simple cysts, complicated, complex, and fibrocystic changes. Okay, so man, I tried to put everything like an index card. I tried to make it like an index card. I'll put my little description of the pathology and I have an image of it. Okay? So with a galactocele, that's a milky cyst caused by obstruction of the lactiferous ducts. Okay, meaning that there's something blocking the ducts and it's getting backed up. It's going to create cause a cyst on the back end. Okay? In pregnant or lactating women, that's a galactocele. Mammographic features is going to be radiolucent. Okay? And sonographic features. Again, the reason we talk about mammographic features is because we work directly with the, we don't do an ultrasound until we have a mammogram. Okay, I'm not saying that you guys have to know how to read mammograms. Of course not. It definitely helps. Just like if you know how to read CAT scans, it helps you with ultrasound, right? Because we take the same axial slices that the CAT scan takes. So it really helps us out. The axial and sagittal slices look exactly the same from what we take versus what the CAT scan is. And so it really helps you out. But I'm not saying at all that you have to know how to read mammograms in order to do breast ultrasound. Okay? So sonographic features include oval, world circumscribed, unilocular or multilocular, flat fluid levels, right here, flat fluid levels, you can see it leveling off, and the absence of blood flow and posterior enhancement. See that posterior enhancement down there, okay? So a galactocele, again, it's a milky sample, so it won't, and when you put the color Doppler on, the color Doppler will not be internal, right? Like we have with our fibrocystic chains.
So would you say that's a complicated cyst?
Definitely. Well, I wouldn't say it's complicated. It looks more complex.
Complex.
I'm sorry. It is complicated. I'm sorry. I'm messing up the terms. It is more complex. I can't say that any of these are solid structures. They don't look pretty. They don't look solid. Remember, a solid structure is going to be very echogenic. You're going to get really bright reflections on a solid structure. I would say this is a complicated cyst line. So that's our galactocele. This is, again, all of my pathology are done like this. This is my little summary of every pathology. All right. So here's our sebaceous cyst. You can see right here by the image, it's going to be a very superficial cyst, very close to the skin. Okay. It's a small skin appendage mass from obstructed sebaceous glands or hair follicles. So you can get these, like you have I don't want to say like ingrown hair, like me having really, really curly hair. I can get like really ingrown hair. My hair can just curl back up into my face or something like that. Okay, causing sebaceous cyst. But you can have these on the breast, of course. Often near the axilla or inferior medial margins. Okay, again, you will see these a lot. And sonographically superficial, claw-like, low to medium echoes, and no internal Doppler. And they may require a standoff pad because they're so close to the skin. You can even see it, how it changes the skin layer right there, right? Just looking at this, I can tell they use a standoff pad for these images right here because we can see the whole skin line so clearly, right? So if you're doing anything, a bump that's raising the actual skin line, you want to use a standoff pad, or you want to use some kind of, fill a glove up with water and use that as your standoff pad. These are sebaceous and epidermal inclusion cysts. Very, very superficial. Very superficial. Okay. Mastitis, guys. Mastitis. Most often presents during pregnancy and lactation. You can even see some fluid levels right here. Non-lactational forms include a ruptured cyst or ectatic duct, post-surgical infection, periductal inflammation, or granulomatous conditions. Okay? Without treatment, an abscess may develop. Okay? Meaning, and you know, an abscess known to be an infection. Treatment being like some kind of antibiotics. Okay? Mammography compromised because of pain. Have you ever had that where somebody couldn't get their mammogram because they were in so much pain? I'm sure, like on an abscess, you can't do those, right? Depending on the person.
I will do it as long as it's not about to explode, you know.
Have you had it explode on you before?
No, not at all.
Cause you can kind of see like the head of it, right? If it is like a pimple.
If it's that bad, when we look like, you know, where I work with Dr. Wynn, he would probably go for ultrasound first
Mhm.
to kind of see where it's at and then.
Okay. Wow. All right. So sub-areolar thickness, nodularity, sticky nipple discharge, and nipple retraction are signs of this pathology, mastitis. Dilated duct shows thick isocoid walls with internal echoes. You can see this duct right here is dilated. And again, you want to have that radial scanning in order to be able to see those, visualize those ducts. Okay. And here's what an abscess looks like. And this is what you see most of the time. Well, I see most of the time when I do this. Okay. Abscess, pus and necrotic tissue. Most are beneath the nipple. They're going to have fever. They're going to be warm, have pain and reddening and thickening of the skin. Even like you'll even feel it that it's much firmer than the breast would normally be. Okay? Sonographically depends on the stage of that abscess. Okay, you can have edematous breast, reduced delineation of Cooper's ligaments, dilated lymphatic channels, liquefaction and tissue necrosis, and antibiotic treatment is necessary. Again, I don't know if they don't. I think they just use antibiotics. I don't think they always try to aspirate on those, do they?
What is it, on the abscess?
On abscesses.
They're treated with antibiotics.
Drench.
Hmm?
Drench.
Drainage? That's what I'm saying. I don't know if they do that in every treatment. Not in every. It depends because sometimes, like this one right here, I wouldn't think that they would try to drain this one because it has so much. It's so complicated. You know, it has so much stuff going on in it that it's not enough fluid to probably try to drain versus the amount of other materials within that cyst.
So not all abscesses are drained, or is it because it's the breast?
No, it depends on the amount of fluid within them, right? If it's not a lot if it's very, very, very complicated, then why drain something that you're probably not going to get anything out of? You got me? Or you know, I know sometimes they lance it or something like that and pack it, but that's like a longer healing process when you have to do that. So I think primarily would be antibiotic treatment before anything else. And Mondo disease, guys. Mondo disease right here consists of a thrombophlebitis of the superficial veins of the chest and breast. Okay, meaning that there's a clot within the veins of the breast. Okay, lateral thoracic, thoracoepigastric, and superior epigastric veins are most involved. That should have been highlighted. Okay, the risk would be injury, surgery, infection, hypercoagulable state, meaning that you're more susceptible to getting blood clots. You have thicker blood in a hypercoagulable state. Your blood is very viscous. Okay? Pregnancy, dehydration, and cancer. You have a tender cord-like superficial mass, and really tender cord-like. That's consistent with all kinds of like blood clots within veins. Okay? If it's especially if it's superficial like these are, you're gonna have that cord-like feel because you're probably that whole vein is gonna be occluded and you can actually feel the whatever is in there, you know, because it's very superficial. Okay. Sonographically, a dilated tubular vein like this right here with internal echoes from clot, absent blood flow, and edema. Okay, so when you look at those superficial vessels, you're gonna be putting color on those to see if they accept color flow, which they probably will not. Guys, whenever you don't have color flow with regular Doppler, always use the power Doppler as well, because you're telling the doctor that this for sure doesn't have flow, right? Like when you're doing a testicular exam, or when you're doing a